This time, I'd like to call the Committee on Legislative Oversight of DHHR to order. I would remind the members this is a little different. As you see the little microphones in front of you at the table height, they're always hot in this room, so I'll remind the members of that for their edification. And the presenter today is Commissioner Cindy Bean from the Medicaid program, and we don't have a quorum yet to approve minutes, so we'll come back to that if we get a quorum. The clerk will continue taking the silent roll. And with no further ado, we'll call Commissioner Bean to the podium. And as the custom of this committee, I do have to swear you in. Do you swear or affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
The podium is yours.
Thank you. Cindy Bean, Commissioner Medicaid. Good afternoon, everyone, and a beautiful day in Morgantown. It's my understanding you have a tour after this, so I will try to make my remarks as thorough as possible and as quickly as possible. So before you, you have a notebook that we have presented. It looks like this. I do have a PowerPoint that I'm going to go through that kind of highlights the different sections of the notebook. There were 12 questions posed to the Bureau for Medical Services, and I'm going to go through each of those questions so you can either follow along in the book or follow along on the PowerPoint. It's up to you. And let's get started, since I know that it's a packed agenda today with regards to wanting to get out of here on time to make your next stop. So the first question was to identify and describe the Bureau, including each office division within the Bureau, including the organizational chart set forth for the entire Bureau structure. So at Medicaid, I have a leadership team. My leadership team consists of myself, my medical director, Dr. Jim Becker, that several of you may know, my legal counsel, Romy Ralio, and then I have 4 deputy commissioners. Historically, I've only had 3 deputy commissioners, but this past session, it passed to roll CHIP under Medicaid, and in that legislation, there was a provision that the director of CHIP be a deputy in the Medicaid program. So Stacy Shamblin has accepted that role as deputy of CHIP. My one commissioner, Deputy Sarah Young, she's over my policy and operations, which includes the professional health services, our provider services, our member eligibility services, our Medicaid enterprise systems management, behavioral health, long-term care, money follows the person, and all of our HCBS services and all of those policies. So Sarah Young is somebody who you definitely want to get a hold of if you have a policy question. Our other deputy over finance, which Medicaid has over a $5 billion budget. So finance is very important to us. And so Becky Manning is our deputy over finance. And then our third deputy is Fred Lewis. He is over our Medicaid management, MCO plans, our program integrity, and our quality unit. And as you look on the org chart, pharmacy is actually reporting to me, but Fred takes a very active role in pharmacy as well. The next question you had was identify the number of employees in the Bureau for the past 5 fiscal years, including each office and division, and the number of vacancies. So as you can see, through 2017 to 2022, in 2017, I had 91 allocated positions In 2022, I'm hitting over the threshold at 101. Our vacancy rate is typically anywhere between 19 and 20 vacancies, which is about an 18 to 20% vacancy I'm running, consistently. I will say the National Association of Medicaid Directors does an operational survey and surveys all Medicaid plans throughout the country. West Virginia is one of 3 states with less than 100 employees for their Medicaid program. The programs vary in size, and of course, we all know that there's large states with much larger population. And so the sizes of Medicaid programs go basically from the less than 100 to the high at being over 4,000 employees. The median, the next about 24% of Medicaid programs fall around 200 employees plus. The next slide is CHIP, and we were going ahead and including CHIP as we just acquired CHIP. As you can see, the CHIP vacancies have definitely, and the number of positions have gone down through the years. You'll see a significant decline. In 2017, the CHIP offices were moved to the Diamond Building, and they share a floor with us at Medicaid. Even before the legislation to put CHIP under Medicaid, we were already sharing resources and doing some things with CHIP and absorbing CHIP. So as you see their positions go down, a lot of those functions are being acquired by the Medicaid staff that were already on the floor, and we're already working together even prior to the bill and sharing our resources. The next question was around your past 5-year fiscal budget and then your past 5-year administrative budget. So let's start with the administrative budget. So our total budget amounts, when you look at the federal and state share, is a little over $200 million this past year. Our state appropriations for that is $43 million. One thing that I've been very proud of during my tenure at Medicaid, even though our administration budget has gone up some, if you look at the overall cost of Medicaid services and what I'm spending on administration, I'm consistently at a 3% admin budget all 5 years. In our budget, this is the past 5 years, but you all also asked on the next slide what our budget projections are for the next 6 years. I will say that these projections are changing. We have rate negotiations with our managed care companies that are taking place now. We are seeing a 3% reduction to those rates, which will be a cost savings to the Medicaid program of approximately $300 million. We also, as I announced in Joint Committee on Finance yesterday, we have now indications from the federal government that the PHE will last another quarter, which will mean another 6.2% of FMAP for the Medicaid program that will last us through the calendar year. So each extra quarter of the FMAP gives us an additional $50 million. The next budget slide you're going to see is CHIP. CHIP's budget functions a little bit differently than the Medicaid budget, as CHIP is a block grant program on a 2-year block grant. I can say that CHIP finances are sound. We had a carryover last year of $71 million into the CHIP budget. The match for CHIP has not floored during the 5 years that you're seeing there. The floor for the match of CHIP could go down to 81.81. However, with that, I am assured that we're not going to need additional dollars for CHIP, as we do have that carryover. The next section, the committee asked, what are your statute authorities and legal authorities for running the Medicaid program? So the Medicaid program is a Title 19 part of the Social Security Act. It started in 1965. I will say, just as a side note, I have an employee at Medicaid that has worked at Medicaid in the Medicaid program for 60 years, which is pretty much since the inception of Medicaid. She remembers filling out sheets and paying providers with paper checks. So we've come a long ways, and I think that there's just some retention of some really good staff and dedicated staff to the Medicaid program. West Virginia and state code has determined that the state Medicaid agency is the single state agency to operate the Medicaid program. In 2013, under the ACA, at that time, executive leadership decided to expand the Medicaid program. This is the biggest change that the Medicaid program had taken on in quite a while. I will say this, in looking back at the staff and our projections that we had, as you know, I've been at the Medicaid program since 2005. We had more staff before we expanded and serving 315,000 people than we have now, serving 636,000 people. But with that, I can say that we still get the job done. We run very efficiently, but we do rely a lot on outside contractors, and you'll see that as we talk about the contracts going forward. The next question are the statutory and authorities within state code that are affecting the Medicaid program. I have several of these listed. I don't want to read you all of these statutes. I will just highlight a few that I think are prominent to this body. The dental, which was something that passed a couple years ago. We also have the enhancement to cover postpartum pregnant women for a full 12 months, which passed also a couple years ago. We also have, as we've gone more and more to a managed care environment, West Virginia Medicaid is at an 85% managed care environment. The legislature asked for additional managed care utilization reports, and that's in statute as well. And telehealth services is in statute, and I will say one of the things that has happened during COVID, it has really opened up telehealth for the Medicaid program and for the better, and it's provided some remarkable access to our members, and it is something we want to continue to do post-pandemic. The next slide, this basically tells you what authority it is that we use for CHIP. CHIP is in 42 CFR Part 47 of the Social Security Act. And CHIP is basically a program that serves children up to that 300% poverty level. So much different program than Medicaid, as there is some premiums and co-payments, and it is block grant funded. The next question you asked was, is there duplication and overlap within some of the functions of what you do and the different bureaus within the department? And my answer to that is it's not so much duplication as an overlap as more of a partnership. I've listed several of the partnerships here that we have in the Medicaid program. For example, our Bureau for Family Assistance, which is something most of you are very familiar with, they process our applications along with SNAP applications and TANF applications. So it's kind of a one-stop shop for a constituent who is in need of Medicaid services. What we do at our office is determine the policy that they use at the county offices to produce and do those applications in a timely manner. The Bureau for Behavioral Health is also a partnership that BMS works very closely with. We have several grants, and one of the things that we're working very closely with the Bureau of Behavioral Health right now on is our CCBHC program. That is legislation that this past session in order for us to create CCBHCs out there in the community to enhance and strengthen our continuum of care for behavioral health. We are working closely with our sister bureau and Commissioner Christina Mullins and having work groups and meeting weekly with that, as it will change the payment structure of how we pay community behavioral health in the future. The Office of Inspector General. We highly use the Office of Inspector General because they process all of our hearings. So a member is denied a service, perhaps they've applied for one of the waiver programs and they don't meet medical eligibility. The Office of Inspector General and those hearing officers, they hear those cases for us and hear those appeals. Also through the OIG office, the Office of Health Facility and Licensure helps us tremendously with regarding our providers that are out there and making sure that they are properly licensed and following up on complaints and a variety of activities there. The Bureau for Public Health. The Bureau for Public Health really helps us in the administration of the Children's with Special Needs program and also our EPSDT program. Our EPSDT program for children under 21 is a critical program. It's a critical program to find some preventative care for children before it ends up to be a crisis model. So they do the training for us for the physicians, they update the forms and do the reporting for us for our EPSDT. The Bureau for Child Support provides information regarding insurance coverage, and so we can do our third-party liabilities. Also, the Bureau for Public Health, and you'll see that's in our list of MOUs, helps us with our Medicaid management system, making sure we get the death file and different statistics so we can report correctly and make sure that we have the appropriate members on the Medicaid rolls. And last but not least, the Office of Program Integrity, which is under the Medicaid program, which is required, partners with Medicaid fraud. Medicaid fraud was recently, I think a couple years ago, moved under the Attorney General's office, so we meet with them periodically and work with them collaborative with fraud cases. The next question was about what kind of technology do you use, and can you give us some examples of the different contracts that you utilize for technology? So the Medicaid enterprise system has really come a long way since Virginia was writing out that check to Dr. Jones 60 years ago to actually, providing things in a very timely manner with regards to claims and electronic claims. And so the Medicaid enterprise system is required from CMS. The system serves approximately, our membership right now due to PHE is up to 636,000 members. We definitely use our MMIS system for program integrity, for our managed care support. They do all of our pharmacy claims, our provider enrollment. We have over 65,000 providers enrolled. Now, when I say 65,000 providers enrolled, you're going to see coming forward on the slide about electronic verification. Our enrollment requirements have definitely expanded from just being your hospitals and your doctors and your nurses and what you typically think as a Medicaid provider being enrolled to actually direct care staff that are in the home and community have to also be enrolled now. Our next slide describes the electronic visit verification system. The EVV solution is an automated process to confirm or deny whether personal care systems are delivered in the home. This is a requirement of the 21st Century Cures Act. if West Virginia did not implement an EBV process, then we would be penalized each quarter 1% of our total home and community-based spend, which would be significant as we have quite a number of individuals receiving home and community-based services. So basically what the EBV does is assure that those members are receiving those services in the home. So the personal care worker goes to the home, and the electronic verification system has a login so they know when they're in the home and a login when they left. So it also combats fraud and abuse, so you can't really be in two places at once.
Interrupt you just a second.
Sure.
Before you take us, we do have a quorum, and I need to do just a little business.
Absolutely.
We'll give you just a rest. A quorum now being established, the chair looks to the co-chair for the purpose of a motion to approve the minutes of the previous meeting.
Thank you, Mr. Chairman. I move we approve the minutes of the April 26, 2022 meeting.
The gentleman moves that we approve the minutes of the previous meeting. Is there any additions or deletions? None being seen, the gentleman's motion is before us. All those in favor of the gentleman's motion, please signify by saying aye.
Aye.
Those opposed, no. The ayes appear to have it. The ayes do have it. Turn it back over to you. I declare the motion adopted.
Thank you. The next use of technology is the Health Information Exchange. The Health Information Exchange is considered a critical healthcare data exchange and infrastructure in support of the state's Medicaid population. The HIE is required under the Federal Health Information Technology for Economic and Clinical Rule, the high-tech rule. We utilize the HIE to really provide some really real-time alerts for not only some of our treating providers. Our MCOs use the HIE, and as well as KeyPro, which is one of our vendors who do utilization management. The next piece of technology is the asset verification system. This is basically electronic asset verification system that confirms, disclose liquid financial and hard real property vehicle registration and assets, and identifies undisclosed liquid financial and real property needs. And so basically this is this system that is utilized as you apply for services such as Medicaid, SNAP, TANF, to ensure that you're not hiding assets, that you have no assets that would count against your eligibility. This, too, is a required system per CMS. The next question was, does the Bureau recommend that we continue Medicaid and its bureaus, or should anything be consolidated or terminated? I feel, of course, we should continue the Medicaid program. Then with regards to consolidated or terminated, I don't, with consolidation, it is more so partnerships. I think you'll look through this presentation and you'll see between the MOUs and the partnerships, the Medicaid program partners with quite a few different other bureaus within the department, and with regards to terminated, we do not feel that needs to happen. The next questions are starting to go into our contracts. So the first page of contracts that you have are very unique contracts, as these contracts are really paying for medical services. So these are our contracts with our 3 MCOs. When you see Coventry, that is also known as Aetna, that in our system they're Coventry. So if there's confusion there. So Coventry has 2 contracts, our Mountain Health Promise contract, which is our managed care for our foster children. And then they also have managed care through our Mountain Health Trust. And remember, 85% of our population is in a managed care environment. The percentage of the population that is outside that managed care environment are long-term services and support, such as your home and community-based waivers and nursing homes. We also have Unicare and the health plan. We went ahead and put Medicare on this slide because it is also paid much like MCO, which means they get a PMPM or a cap rate for the members that they serve, and out of that, they have to provide the services, and that is our NENT broker. The next slide goes through several of our contracts. If you look at the different columns, what you'll see is the state and federal. What you'll see is the state and federal amount, and okay. What you see is the state and federal amount, and then the state and federal paid, and then the state dollars ordered, and then the amount paid. So the first contract is a contractor that we do rely on heavily at the Medicaid program. That contract is with Barry Dunn. They provide most of all of our project management. This is a fairly new contract. However, they are a long-standing vendor. And so this is what we have in our new contract for them to provide for this year. Our next is Gainwell. So Gainwell, some of you might know them as Molina, some of you might know them as DXC. They've changed their names about 4 times throughout the last 4 years, which is really something that Oasis loves. And so Gainwell is our fiscal agent that pays all of our claims. The next contract, and this might be a little confusing, but we wanted to make sure you had all the information, is IBM, who does our original data warehouse. The reason they are on there twice is they had changed their name. And so the way that those dollars come out of the Oasis and the system makes them on there twice. And then the next contract is for the larger IBM data warehouse contract that is fairly new. Change Healthcare works with our pharmacy department, and they actually work with our PDL. On the next page, Health Management Systems. Health Management Systems is our contract that really does our TPL and also manages our MWIN program. The next contract with Public Consulting Group is for our school-based health services. They do time studies that are required with our school-based health services plan per CMS. The next contract is for some accounting that helped us with our audits for our DISH program, and DISH dollars go to the hospitals. Our next contract is for Myers and Stauffer and our actuarial services. So with our managed care plans, one of the key ingredients to doing managed care is that you have to have an actuarial team, and your rates have to be actuarially certified. Our next contract was Maximus, and Maximus is our longstanding enrollment broker who makes sure that individuals that are signing up for managed care have somewhere to call if they want to ask about the different plans and assure that they are assigned to a managed care plan in a timely fashion. Our next contract is with Clarence. This is our EQRO. This is also required by managed care to have an external quality and review. And our next contract is with Kepro. Some of you might know them as APS Healthcare. As you see, there's like no amounts on there, and that's because we just renewed the Kepro contract. I will let you know that the previous contract, since you don't have those amounts on there, for Kepro was $26 million, and then our state portion of that was $6.5 million. Kepro is our quality improvement organization, so that is at a 75% match. Our next contract is with Psychological Consultants and Assessment Services. This is our contractor that provides our assessments for our IDG waiver, as well as our assessments for our PASS-R Level 2, if you need to go into a nursing facility and require that additional assessment. Our next contract is for the home care software, and this is the electronic visit verification that I mentioned earlier, which is what is used in our home and community-based programs to make sure the worker is actually out there in the home working. Our next contract is with Public Partnerships Llc. This contract is paid also on a PMPM, and this is for individuals in our home and community-based waiver programs that are receiving self-direction. This contractor provides for resource consulting, which means somebody going into that home, checking on that waiver participant, and also provides financial services with regards to hiring, firing, tax services, and processing payroll. Our next contractor is Oahc Advisors, and they do our appraisals, which are required for our nursing facilities. Our next contractor is with Lewis G. Brewer, PLC. We have yet to use this contractor for probably a couple of years. I think we do have a hearing coming up. This is our administrative law judge, and it's basically $100 an hour is what the charge is for there. Our next contract, you'll see some blanks in that because it's 100% federally funded. Our Money Follows the Person program, which is a program that helps individuals transition from a nursing home back into their community, uses the Metro AAA to hire some coordinators to go into nursing homes to help facilitate those moves. Our next contractor is First Choice. We use First Choice to help us with the tobacco cessation line. Tobacco cessation is a required service for pregnant women. However, we provide that service for all the Medicaid population due to the need of tobacco cessation programs in West Virginia. Our next contractor is the West Virginia HIN, which is the HIE, which I spoke about previously, which is a required activity through the HITECH Act. Our next contract is a membership for the National Association for Developmental Disabilities. As running the 1915C waiver program, it is imperative we are a part of that organization to know the new things coming down the pike with regards to ED services. Our next contract is the Medicaid Evidence-Based Review contract. This contract is mainly used by our medical director and our medical team, and we utilize this contract for research. As new things come down the pike, we're always getting requested, can you cover this? Do you want to cover this? And how much do you need to cover it? And we really utilize this contract to do some of that research for us. And then our last contract that we have is for the National Association of Medicaid Directors, and those are the dues for that membership, and every state and territory in the nation belongs to that organization. The next slide is CHIP. I'm not going to go over all their contracts. However, I am going to highlight that CHIP, as you can see, was already piggybacking on our BMS contract for Kepro, Maximus, Gainwell to do their fiscal agent, HMS, and Barry Dunn. They did work with PAA for their PBM and also their actuarial services, and then they do have a small contract for their helpline as well. The next question you asked was about memorandums of understanding and what are all of our memorandums of understanding within the Bureau. We have several memorandums of understanding. The first is with Public Health. I don't want to read all these to you, but as you can see, our different memorandums of understanding, especially the first couple with Public Health, one's about sharing data, one is on our breast and cervical cancer program where BMS, we utilize them to capitalize on the match of a 75-25 admin. The Bureau for Public Health, the Right from the Start program, the Children with Special Health Care Needs, the Ryan White program or the ADAP program. We also partner with Public Health for the Office of Maternal and Child Health. We also have the MOUs, as I spoke to earlier. Oahc does all of our reviews and licensing and certification. We process claims on behalf of the Tiger Morton program. We also do some information for child support. And then we also have an MOU with the Attorney General's office for the Medicaid Fraud Control Unit that is now under the purview of the Attorney General. The next question was about what are the services that the Office of the Secretary provides to the Bureau for Medical Services. And so one of the things that the Secretary's office provides us is supports with communications. They make sure that our communications are all uniform throughout the Bureau, and if we have additional questions about communications or press inquiries, those go through the Communications Office. They also provide us support with the General Counsel. My General Counsel consults with April Robertson, who is the General Counsel for DHHR, and really discusses and talks about cases and the risks for Medicaid and the agency. They also support us with the Management Information Systems, the MIS office. And so they provide information to the department for enhancing our services with MIS. They also help us with human resource management. There's the HR office, and then also administration and purchasing, and also client services or constituent services, which a lot of you have probably talked to John Lopez through the years and know that he helps us tremendously and fields questions, and then is very good about coordinating those questions when he needs information from the Bureau for Medical Services. The next slide is basically what is required of the Medicaid program. What are you required to provide? So Medicaid is a very regulated program, it's a state and federal partnership, and there are certain services that we are mandated to provide. In those services, what you'll find is like, well, you're not mandated to provide pharmacy. Well, we're not. It's not a mandated service. It's an optional service. However, it doesn't make sense for us not to provide pharmacy. So I have listed on this slide all the mandated services that CMS says in order for you to operate a Medicaid program, you have to provide these services. The next slide shows you all the optional services. So a lot of the optional services that you'll see are, while they are optional at the federal government, they're probably not really optional for good health care for the state of West Virginia. Mm-hmm. So with regards to optional services, you'll see things on there like hospice. Hospice isn't a service we would necessarily ever want to cut. You'll see things on there like occupational physical therapy. Those are things we would not want to cut in the state of West Virginia, but however, these are our optional services. So if we ever would get into a situation where the Medicaid budget would need to be cut, these would be the services that we would have to look at if we were doing any kind of service cut. The next couple slides, you're going to see what CHIP is required. So the CHIP requirements are a little bit different because with CHIP, you're going to say like, well, CHIP requires a lot more than Medicaid. But there's the caveat in CHIP. And the caveat in CHIP and how the statute reads, it says CHIP can cover things in whole or in part, meaning they don't have to cover the full gamut of services that we have to cover in Medicaid. So you're going to see like prescriptions on CHIP as it's a mandated service that they can cover in whole or in part. So a lot of the services with CHIP, if we would ever need to cut or have any kind of situation with CHIP, what we would have to do is not necessarily cut an entire service, because you would need to in part, provide some of that service. And I'm not going to read all those to you, because I want to save plenty of time for questions. The next question was about interagency funding received. VMS doesn't receive any other funding within DHHR other than the MOUs that we've previously listed, and neither does West Virginia CHIP. So that's a quick overview of the questions that you all have asked. And like I said, the presentation itself kind of gives you a quick overview. There's more detail in your book. Under each tab, we've listed the question and then the answer. I'm available for any questions.
Thank you, Commissioner, for your presentation. Do we have any questions? Delegate Tully.
Thank you, Mr. Chairman. Thank you, Ms. Dean, for being here. I have a question actually about your MCO contracts, and I think it's on page 16 in the binder. It's under section 8, I believe. Are those the totals? Is that from 2020 forward as of July 2020, July 1, 2020, or 2021? Can you tell me where you're getting those numbers?
Let me look real quick.
Okay.
I'm sorry, what page did you say?
16.
Thank you. I believe those are last year's numbers, but let me double check on that for you just to make sure I'm giving you the correct amount.
The correct fiscal year. Okay. Great. Thank you.
Delegate Summers.
Oh, thank you. Thank you, Commissioner Bean. Very, very good presentation, as always. I have a couple questions. One, can you talk me through, the Medicaid budget is so massive, but I realize as we talk through state government, we're like, oh, they receive Medicaid money for that, or oh, they get Medicaid money for that. What other places do you ship Medicaid money to within DHHR or other places in the state?
So within DHHR, one of the things about Medicaid and one of the unique situations that Medicaid has is all of my administrative staffing is either at a 50-50 match, or if you're medical in nature, such as you're a nurse performing in a nurse capacity or a nurse policy capacity or a doctor, that's a 75-20-25 match. So we do have a lot of the different bureaus that are doing administrative activities for Medicaid, such as BFA. Some of their employees are at that 50-50 match because Medicaid, they're processing those Medicaid applications. OFLAC. A lot of the OFLAC reviewers, because a lot of those are nurses, they're at a 75-25 match. So we're pulling down as much federal dollars to fund those positions as we can because they're performing activities for Medicaid. The committee did not ask around other bureaus outside of DHHR, but you know, another example of things that we do, we have a partnership with the Bureau for Senior Services that works with our age and disabled waiver, and so they receive Medicaid administrative monies as well. So those are some examples, Delegate Summers.
Well, when you talked about that huge list that the Office of the Secretary provides for your bureau, do you pay them then for those services? Does that come out of your Medicaid budget? Is that an expense that you have then?
Yes, and, I have those numbers. What you saw on the administrative, chart is what the state appropriation is. And typically, and I can get you the exact numbers, around $4 million off the top of that goes to the Office of the Secretary to provide for administrative services that they assist the Medicaid program with.
Okay, yeah, because I was reading the 43 million, and then you had 100 employees.
Yeah.
So I wasn't sure what all the services included that was coming out of that, so, okay. Another question I have for you is, a lot of times we are spending time reviewing all the rules of the different agencies. How do you do that with Medicaid, with the waiver programs and the, you know, the state plan, all these things that you guys decide? Is that just decided on the executive level? Because I don't think that the legislature has input on that for Medicaid, but I know we do have input on other rules for other agencies.
Yeah, so the single state authority is not subject to rulemaking.
Okay.
However, we do have a very, strict policy, and one of the laws in the slide that had all the different state statutes, one of them mentions our policies of what we have to follow with proposing new policies, rules, and state plans. So if the Medicaid agency does a state plan, not only do we have to do public notice to our constituents, we have to advertise that public notice. It also goes through our Medicaid Fund Advisory Board, which there is legislative seats on that board. And then any of our policies have to be posted for 30 days. We have to consider comment before we post them as final policies. And it's all kind of outlined in a very stringent process that is also in state statute.
Okay, because I worry sometimes some things that are made, some save us money, but some cost us money, and I was just wondering. Okay.
Right.
And my last question was, you talked about the different technology you have. What improvements do you still need to be able to, do you need to see to be able to operate more efficiently?
So with Medicaid, our technology piece is very dictated, and what you'll see, one of the things, the reason we've been able to keep our admin down, which I'm very proud of us being able to keep our admin down to that 3%. We work very hard doing that because we always try to maximize the state dollars. And so anytime there's a 90-10 opportunity, we are going after that 90-10 opportunity and trying to encompass as much as we can in that 90-10. And with the Medicaid enterprise system, the feds have very strict rules of what you have to do for that system. In fact, right now, the rules are kind of shifting with regards to now they want modular systems, not one big system that can do everything, but systems that can plug and play in different kind of an integrator. So we are pushing towards that, and that's our next new thing that is required by CMS that we will be doing. And we've had an RFI out with regards to interest in our modular systems and got a tremendous response. I think we got over 20 responses on the RFI. So those different RFPs will be forthcoming in the next couple of years.
Does Enterprise do that? Is Enterprise the name of the system or the name of the program? Like I'm saying, could Enterprise be the one that creates these modules out of things they've already done? Or you have to
your
get a new
Medicaid
system?
enterprise system, it's your claim system. It's who does your provider enrollment, who does your enrollment broker. It's who does, trying to think some more examples of it. But it is basically all your different technology pieces is considered your Medicaid enterprise system.
Okay, thank you.
Delegate Reed, did you have a question?
Yeah, thank you. Thank you, Mr. Chairman. I actually have an odd question. I know a couple of years ago, we moved the medical fraud control unit over the Attorney General's office. Has that helped? Have we done better looking at the fraud issue by doing that versus being put underneath the DHHR?
I really can't speak. A lot of things, once they go to fraud, there's sometimes year-long investigations, and so I really can't speak to what all or the different reports that the Attorney General's office has. I do know that we meet with them and we work collaborative with them, but as far as the recruitments and the number of recruitments, I don't have that answer. The Attorney General's office would have that.
Okay, thank you.
Senator Stallings.
Thank you, Mr. Chairman. Cindy, would you
have any idea, or would you care to ponder what, having 85% of Medicaid into managed care has done for the bottom line, or medical inflation, or anything like that?
Well, I'm sitting on a surplus. Now, a lot of that surplus is due to the PHE, but I'm gonna save even more money this coming year because my, actuaries are putting my rates down, and it makes it more predictable as well. So managed care in the Medicaid program has really saved us, a lot of money through the years. As different programs go into the managed care environment, we'll see an initial savings, and then it'll level out, and then you gotta continue to account for medical inflation. But our managed care companies not only provide that savings, they also provide, care management and a sense of quality and reporting that we really didn't have on the fee-for-service side. And so, it is the wave of the future. It is, what the majority of Medicaid states, have gone to.
Yeah, I mean, I would guess hundreds of millions of dollars, but I just know.
I don't have the number in front of me, but it is quite a few.
I know that, a lot of people that's been around a pretty long time, certainly remember that, nearly every year we were having to put another 80 million or whatever for the state match. And I know that the managed care, system, clearly, I think has really helped the cost of the Medicaid program. That being said, a couple years ago, we passed legislation to provide adult dental care for indigent Medicaid. Do you have any idea what the state's share of spend is on that? How much we've spent?
I don't have it broken down by the state share, and the only reason I have this off the top of my head, Senator Rawlings, is because I was on a call with the dentist Friday, and so I know last year we spent $31 million total on the adult dental program.
Right. And that includes both federal and state?
That includes both federal and state.
Yeah. And it's the group that came in later were 90-10 match, and the traditional Medicaid is 70 is what the FMAP is now?
Right. It's a little higher right now because we're getting that 6.2% throughout the end of the PHE, but typically, without the PHE and the public health emergency, we're more around that 74-75%.
Thank you.
Any other questions of our presenter? Delegate Tully.
Sorry, I thought of one more. Actually, this plays off of Delegate Reed's question about the fraud unit going to the Attorney General's office. If there's recovery of funds from anything that runs through that fraud unit, does that money go back in your budget, or does that stay with the AG, or how is that handled as far as financial recovery from fraudulent activity?
So financial recovery from fraudulent activity, one thing, CMS wants their portion. And so CMS is definitely going to get their portion. And so if you think about it, if it's, $100,000, $75,000 are going to go back to the feds, and then the $25,000, I would have to look at our MOU with the Attorney Generals to tell you how that is split and if it is split.
Thank you.
Delegate Reed.
Yeah, I've got one more question. So the last meeting was I heard testimony that Medicaid was chronically underpaying providers to a certain degree. Does CMS have some type of equation that they use to make those numbers fit?
I don't believe that Medicaid underplays providers to a huge degree. And I'm not sure what provider group that was. I do know that as things come across, as we do new spas, new services, CMS has to approve not only the spa plan with regards to the policy, but also the financial page. So if we would propose something that would be financially insolvent, they would come to us and be like, this isn't going to work. Also, if we lose a provider network, and it's imperative that rates increase, that is something. I will say this, that the risk to the Medicaid budget that I see forthcoming is We've been very good about holding our medical inflation down to, close to 1% to 2%. I do see additional risk coming just because with the pandemic, there has been a shortage of workforce out there, and the prices that you're having to pay to have workforce, especially in our HCBS, services, even though we were able to give them, some relief through, the American Rescue Plan funds, I do think that that is a risk for the future with regards to that.
Okay, thank you.
Okay. No further questions being seen. Is there any other business to come before the committee at this time? No further business being seen. The chair looks to the co-chair for the purpose of a motion.
Mr. Chairman, I move we adjourn.
Co-chairman Woodrum moves that we adjourn. All those in favor of the gentleman's motion, please signify by saying aye.
Aye.
Those opposed, no. The ayes appear to have it. The ayes do have it. I declare the meeting adjourned.